I just hopped out of a shower, so my hair is kind of wet. You may have heard somewhere that doctors may be stopping aspirin 1 month after a heart attack rather than keeping on it indefinitely, based on a study that was presented at the American College of Cardiology earlier last month. A few other important studies were presented at that conference as well, including whether to continue beta blockers after a heart attack or whether to start something like empagliflozin, which is a diabetes or heart failure medication, immediately after a heart attack. This video is part of a two-part video series where I'll be going over the details of this ULTIMATE-DAPT study as well as the reduced AMI study, details that the average doctor might not even know or think about. But you, on the other hand, will know the ins and outs of these studies and how they may influence practice. The study today is ULTIMATE-DAPT, DAPT. I've interpreted this strategy of stopping or dropping the aspirin after 1 month of dual antiplatelet therapy for certain individuals, such as those with very, very high risk for bleeding and relatively low risk stenting procedure or PCI, done with a special tool called IVUS, and I'll go over that in just a bit. I think it would be helpful for me to go over and review some of the background studies that this trial was based on. One of the main reasons why I think this trial was done was all the other studies were done as open label trials. This was the very first one that was done as a randomized double-blinded placebo-controlled trial. The problem with open label trials is that it can introduce something called performance bias, where knowing the actual treatments, whether it's a patient, the clinician, or researcher, can actually affect the differences in the outcomes. For example, if you were to be put in a study and you were told that you were getting the placebo as opposed to the study medicine, would you possibly want to seek other therapies on the side? Maybe. Or if a researcher was heavily invested in a study and knew that you were getting the treatment, they may treat you a little differently, possibly better. I don't know. A systematic review done in 2012 looked at the effect of lack of double blinding of both patients and researchers and what that can do. It showed that studies with a lack of or unclear double blinding had an effect size on average about 13% higher than studies with very clear double blinding. But just because they did not blind the patients doesn't necessarily mean that the studies were complete garbage. I'll still briefly go over some of these background studies leading up to this ULTIMATE-DAPT trial, but if you don't care to know any of this stuff, and just feel free to skip straight over to my review of ULTIMATE-DAPT. Global leaders looked at Ticagrelor by itself after 1 month of DAPT with aspirin and Ticagrelor versus standard therapy. And the standard therapy was dual antiplatelet therapy with aspirin plus clopidogrel or Ticagrelor for 1 year, followed by 1 year of aspirin. Unfortunately, the study was underpowered. Patients did receive this fancy European biolimus drug-eluting stent, which is a biodegradable polymer. There were some quality issues with drug adherence monitoring as well for that trial. STOP-DAPT-2, they used aspirin plus clopidogrel for 1 to 2 months, then dropping the aspirin. That failed to reach non-inferiority for their net clinical benefit outcome. And so there was less bleeding, but more cardiovascular events. It had issues with randomization, which happened to bias the comparison towards no effect. It was substantially underpowered for the efficacy outcome, and it had a numerically higher number of events, although not statistically significant because it was underpowered, in the shorter duration of DAPT arm, given the possibility of clopidogrel non-responders in the Japanese population. Twilight trial, where they looked at 3 months of DAPT with aspirin and Ticagrelor specifically, followed by Ticagrelor by itself. Twilight did not include STEMI patients, so those with ST elevation myocardial infarction. About 60% of them had NSTX or non-ST elevation ACS. About 30% of patients were actually asymptomatic, so they didn't have any symptoms, no chest pain, no nothing, which suggests a possibly lower risk population. Twilight also excluded patients who were at high risk for bleeding. Ticagrelor by itself, after 3 months of DAPT, had less bleeding overall as expected, and there was no difference in the composite outcome of death, MI, or stroke. SMART-DATE compared 6 months versus 12 months of DAPT. About 80% of them were on clopidogrel following an ACS plus PCI, where 6 months of DAPT had statistically higher risk for heart attacks compared to 12 months of DAPT. And it found that numerically, too, that there was a higher risk for stent thrombosis in the 6-month arm. So that's kind of scary. Bleeding was no different, which I thought was a little strange at first, but I suspect this may be because there was not a long enough time gap between 6 and 12 months for them to be able to see a difference. Smart Choice compared conventional year-long DAPT versus 3 months of DAPT, and about 80% had clopidogrel as well, followed by monotherapy P2Y12 inhibitor, which showed non-inferiority for their MACE outcome. Good chunk of these patients were stable, low-risk elective procedures, about 40% of them, and there was no difference in bleeding. The TICO trial achieved something similar to Smart Choice, with Ticagrelor as the P2Y12 inhibitor rather than mostly clopidogrel. It was 3 months of DAPT and dropping aspirin afterwards. They took it one step further and included bleeding in their primary outcome and noted that bleeding would be lower with shorter duration DAPT. TPAS used a bioresorbable polymer drug-eluting stent in the ACS setting, and it looked at a similar combined net CV events outcome, so death, heart attack, in-stent restenosis, stroke, as well as bleeding. But it also took it one step further and cut back even further on the duration of dual antiplatelet therapy by dropping the aspirin within 1 month of PCI. And on average, it was about 16 days following PCI. They also found that dropping the aspirin did better for the overall net adverse CV outcome, driven primarily by bleeding. There was seemingly no difference in the outcomes for death, heart attacks, or restenosis. It did have relatively low event rates, which points towards possibly a lower risk population and excluded high-risk bleeders. Now, Master-DAPT, they included those who were high risk for bleeding and had a very complicated regimen that depended on whether people needed to be on an additional blood thinner. Close to 40% of the people in the study actually needed an oral anticoagulant. Ultimately, they showed that a shorter duration of DAPT was non-inferior to standard duration DAPT for their similar net clinical outcome, which included all-cause death, heart attack, stroke, and bleeding. Bleeding, as you would expect, was lower in the abbreviated DAPT arm. They also used the ULTIMATE stent, which is another fancy biodegradable polymer drug-eluting stent. I guess that's where the name for this trial, Master, came from. So now for ULTIMATE-DAPT. This was published in Lancet, and it was a randomized, double-blind, placebo-controlled trial done in ACS patients who completed the IVUS ACS study. The IVUS ACS study was the first part of this trial that had 1 month of dual antiplatelet therapy, and where they were randomized to IVUS, which is intravascular guided PCI, versus the traditional angiography guided PCI. And I'll come back to this later because I think it plays into it. 58 centers across China, Italy, Pakistan, and the UK primarily was done in China, enrolled 3,399 patients to receive either Ticagrelor 90 milligrams twice a day versus placebo versus standard Ticagrelor 90 twice a day plus aspirin 100 daily. The mean follow-up was close to a year, 347 days. The baseline characteristics, the median age was 62, about 3/4 of them were male, about 90% were Chinese, as it was predominantly, like I said, done in China. 60% had acute MI, and the rest were unstable angina, had normal LV function. Less than 10% of these patients had pulmonary edema or water in the lungs as they presented. Less than 50% were on RAS inhibitors like ACE inhibitors, ARBs, and beta blocker therapy, and about 83% were on statins. A little bit lower than I would expect. Methods-wise, the randomization, allocation concealment, and blinding seemed appropriate. Interesting to note was that Anybody who developed dyspnea or shortness of breath from Ticagrelor, the dosage was actually reduced to 60 milligrams twice a day, and if it persisted, Ticagrelor was then replaced by clopidogrel without a loading dose, based on the physician judgment. Interesting. Stats-wise, they assumed a 3% rate of clinically relevant bleeding for the conventional arm. They needed 3,400 patients to provide 80% power to detect a 50% reduction in bleeding. They also assumed a 6.2% MACE that necessitated 3,068 patients to provide 80% power to show non-inferiority of Ticagrelor plus placebo with non-inferiority margin of 2.5%. The authors acknowledged that there was some uncertainty with deciding on the non-inferiority margin of 2.5%, but they felt that this was a reasonable estimate. I'll talk about this in a bit. Results-wise, it had a co-primary endpoint of safety, which was clinically relevant bleeding, defined as BARC types 2, 3, or 5, which is a bleeding classification system. The co-primary efficacy endpoint was a major adverse cardiovascular or cerebral vascular event, so basically heart attacks or strokes. What the trial found was the following. There was a statistically significant difference in bleeding, as you would expect, 2.1% in Ticagrelor versus placebo versus 4.6% in the conventional DAPT arm, with a hazards ratio of 0.45, 95% confidence interval of 0.3 to 0.66. Pretty convincing. There was also no difference that they could find with the MACE outcomes. So 3.6% in the Ticagrelor plus placebo versus 3.7% in the Ticagrelor plus aspirin arm, with a hazard ratio of 0.98, 95% confidence interval of 0.69 to 1.39. Please note that this is a fairly wide confidence interval considering how many patients were enrolled. They also did a secondary combined endpoint of net adverse clinical events, 5.7% versus 8.2% with a hazard ratio of 0.68. They did various bleeding endpoints, which I'm not going to go over because most of them were deemed statistically significant anyway, but I do not really care because most of them were as expected to be lower anyway. Let's look at a little bit more at the secondary ischemic events and mortality endpoints. All-cause death, not different numerically. Cardiac death was also not different numerically. Myocardial infarction was not statistically significant, although the non-procedural myocardial infarction rates seem to be numerically higher, 16 versus 11. Stent thrombosis was equal in both arms, both at 0.3%, and the rest of the revascularization endpoints were both similar in the two groups. The 3-point MACE was also not different, 1.8 versus 1.9 for the hazards ratio, similar to the 4-point MACE as you would expect. So my overall opinion and comments. First of all, this, as with the triple therapy studies that looked at atrial fibrillation and PCI, we don't need another study to tell us that dropping aspirin, that bleeding risk is going to be lower. We already know that. What we really need to know is whether we get more stent thrombosis and restenosis and heart attacks and strokes if we are to drop the aspirin. This should be the focus of these studies. Bleeding occurred in 4.6% of the Ticagrelor plus aspirin arm, which is higher than the assumption of 3% for which the power calculation was based on. This seems to me like it was probably overpowered for this outcome. So you're more likely to find whatever you are looking for because you simply have more patients than you need. Hence why the p-value is so low. Now for the meat and potatoes. For the efficacy outcomes, it was clearly underpowered, as most trials like these, because medicine nowadays is pretty darn good. And for us to tease out these smaller differences, it would require a lot more patience, and it'll be more time consuming, it'll be more expensive. When you have 6.2% for the event rates that you are aiming for, but you only get 3.6%, it's either you're not studying the right patient population, meaning that they were not sick enough, or the assumption by the investigators was just very off, where there was a chance of not finding a difference when there actually was a difference. And this is what we call a type 2 error in statistics. And this is what we call a type 2 error in statistics. When a study is underpowered, it means that the sample size is too small to detect a true effect, increasing the likelihood of failing to reject a false null hypothesis, which is the type 2 error. Unfortunately, most cardiology trials, despite all the money that's thrown around, are like this. And it's unfortunately too that it's almost just accepted this way. This is one of the reasons why we have to end up doing meta-analyses of studies to boost up the power to hopefully detect a difference. When we look at the design of the study and how they chose the non-inferior margin of 2.5%, this basically translates to a numbers needed to harm of 40, meaning that you need to treat 40 patients this way before you have a difference of the outcomes between the two groups. Is that something that you are willing to accept? Is 40 patients enough? Is 40 patients enough for us to say, okay, we've looked at 40 patients, there's no difference, we're good? It's something to think about. Remember too that patients were enrolled in the IVUS ACS trial for the first month, where they had to be randomized to IVUS versus angiogram guided PCI. Most of my patients get an angiogram procedure done, don't get IVUS. Rather, they get the plain old angiography done under fluoroscopy, which is basically real-time x-ray. This is why interventionalists and the staff working in a cath lab need to wear lead to protect themselves from this radiation. For those who are not sure what IVUS is, it's essentially being able to do an ultrasound within the blood vessel looking for narrowings. It has been associated with better results at 3 years compared to traditional angiography when looking at target lesion failure, as well as cardiovascular death and target lesion myocardial infarctions. IVUS guided versus angiography. There are other ways of looking at blood vessels other than IVUS, such as OCT, which uses near-infrared light to characterize the heart artery plaque, and I'll go over those differences in another video. Even though it's not directly drug related, I do find it pretty fascinating, so I'm going to talk about it. Going back to the study, it was very good how they ensured that all patients got DAPT for the first month, the way that they designed it, as data shows that the highest risk of events tend to occur within the first month of PCI. Patients were pre-selected to have tolerated DAPT in the first month. Similarly, patients were pre-selected to not have experienced a clinical event within 30 days. Because of this, I don't think that this is a decision that we can actually make immediately after a heart attack for the patients in the inpatient setting, and should have their dual antiplatelet regimen reassessed at the 4-week mark. This is usually the time when they're supposed to follow with their cardiologist anyway. Patients with non-adherence issues, I would be very skeptical of removing the aspirin. Ticagrelor's half-life is relatively short, about 8 hours, and we've seen this before where missing as few as 3 consecutive doses can lead to very dangerous things, even with the background therapy of aspirin on board. In the clinical trials, we can assume that adherence is actually very good, if not excellent. In real world, this is usually not the case for a lot of patients. This could mean that patients are essentially on absolutely nothing. We would need to do things like blister packing, daily dispensing, worst case scenario, maybe witness ingestion by nursing staff at a care home, or something like that, for that type of adherence measure to be in place to ensure that patients will stick to the Ticagrelor monotherapy regimen. Obviously, this is just for the straightforward ACS PCI. It doesn't include those with concomitant need for a blood thinner, as they excluded those patients. Those with chronic kidney disease only represented less than 8% of the total population, and we know that these people carry a high bleed risk as well as a high risk for recurrent events as well. They also excluded those with severe CKD, defined as an eGFR of less than 20. So for an advanced CKD patient who comes in with an ACS, I'm not sure if I would feel comfortable even offering them Ticagrelor. The truth of the matter is that there will never be the perfect duration of DAPT therapy that is a one-size-fits-all for everyone. One patient who comes in with a STEMI, and that is their only lesion, will have a completely different risk profile compared to another patient who had a STEMI with several other blockages in other arteries. The length of the stent, how much metal there is, and where the stent is deployed. Is it in a high-risk lesion? Was it deployed in a bifurcating area? Or was it something more straightforward? What kind of stent was used? Did they have one of those fancy biopolymer scaffoldings? Did the interventionalist just balloon one area and stented the other? How much collateral circulation does this patient have? Are these chronic 50-year-old lesions that have been stable versus something that developed rapidly over 5 years? A lot of these studies were done in Korea, or like the ULTIMATE-DAPT, or the majority of them were done in China. Can we really generalize this to the Western side of the world? All these things kind of play into it. There's just simply too many factors that come into play to simply say, oh, 1 month is all you need for dual antiplatelet therapy, or 3 months is all you need, right? We may be approaching, or have already approached, the limits of what medicine can offer patients at a population level for this group of people. Evidence-based practice is geared towards studying particular treatment in a given population rather than on an individualized basis. As clinicians, we are expected to take the population data, interpret it, and try to apply it to our individualized patients. At this point, I think we need to just stop doing studies like these, particularly looking at a bleeding risk, because chances are it's going to be lower anyway. And we should rather focus our attention on either identifying predictors that can be utilized for risk assessment that can be used for making decisions that can be validated in the general population. Overall, I think we need to be very careful how we interpret some of these studies as well. DAPT with aspirin plus clopidogrel, it's not the same as aspirin plus prasugrel, or the same as aspirin plus ticagrelor. Anyway, for a small channel like this one, consider hitting the like button, the subscribe buttons, or even sharing this video with others, which really helps people find this channel. Whether you're a patient, caregiver, nurse, doctor, pharmacist, or student studying to be any of these, consider leaving a comment in the section below for any burning questions that you've had, but you've just never had a chance to ask any pharmacist or doctor. If you want to know a little bit more about ticagrelor and how it differs from clopidogrel, check out this video here, where I review 12 differences between the two drugs. Again, thank you all for watching, and we'll see you in the next one. Say no to drugs.